Good morning, everybody.
Sorry, Dr. Kacham, we can't hear you very well. And do you mind just for the slideshow, maybe, so we can have a bigger screen?
Sure.
Go to
Okay, good morning, everybody.
Yes, we can hear you very well now, Dr. Kacham. Thanks a lot. We can see your slides.
So today my talk will be on the approach to antenatal diagnosis of hydronephrosis. I'm a pediatric surgery registrar at Walter Sisulu. So the concepts that I'm going to be covering today is a few basic concepts about antenatal hydronephrosis, the approach to antenatal hydronephrosis, a few basics of what are the fetal interventions available for management, what is the role of postnatal monitoring and when to actually monitor by the use of a micturating cystogram or a renogram, what is the role of prophylaxis in this group of patients and when to actually intervene surgically. So the take-home message that I actually want to start off with for everybody to remember is the algorithms that give you a basics on how to actually approach these children. So in the prenatal algorithm for antenatal hydronephrosis, once an ultrasound is done, you classify the hydronephrosis according to unilateral, bilateral. It's further classified into mild or severe. Of course, if the child has severe systemic malformations, in our center, we would refer these children to a specialized center, which we refer to Red Cross Children's Hospital. If it's unilateral with mild hydronephrosis, the series of monitoring through means of ultrasound is not as regular as with severe hydronephrosis. With severe hydronephrosis, one needs to monitor the child every 4th to 5th week and bring the child towards term. When it comes to postnatal monitoring or ultrasound, we repeat the initial ultrasound in the first week of life. Again, you classify the hydronephrosis into no hydronephrosis, mild hydronephrosis, or moderate to severe. So the first two groups, these require either no intervention or ultrasounds are repeated every 3 to 6 months. But the group most importantly is the severe hydronephrosis, where these children need regular monitoring. They need a series of a MCUG or a renogram, and therefore that will then take you what is the cause of the hydronephrosis and what are the interventions required to manage the child in the postnatal period. So we'll go through this in the talk. So when it comes to a basic physiological fetal hydronephrosis, in comparison to a neonate, a fetus shares the following ideal characteristics. So there's a low renal vascular resistance, there's high blood flow, high FGFR, lower renal concentrating capacity, and high urine output. Since the fetal and neonatal kidneys are not fully developed, the renal medullary cone may be transparent and under ultrasound examination may result in the wrong diagnosis of hydronephrosis. A few concepts about the basic renal physiology. So urine formation is first seen in the 5th to 8th week. However, it is principally an unmodified plasma filtrate since tubular function starts around the 14th week. The urine output is approximately 5 cc's per hour at the 20th week and increases to 50 cc's by the 40th week. The fetal bladder can be visualized on ultrasound by the 10th to the 14th week, and its emptying can be seen by the 15th week. The bladder capacity is observed to range from 10 cc's at the 30th week to 50 cc's at the term. So what is the significance of the amniotic fluid index? So very early in gestation, the amniotic fluid is principally a transudate of the amnion, while later it is composed of fetal urine and lung fluid. The amniotic volume becomes principally dependent on urine production and around 16th week ranging from 380 cc's at the 20th week to 800 by the 28th to 40th week, almost reaching term. A rough estimate of the amount of amniotic fluid can be determined by using ultrasound and using the index called the amniotic fluid index. So the role or the issue with polyhydramnios, it is seen when there's a volume of greater than 500 cc's. The etiology is very important here, and this includes GIT obstruction, especially in our setting, multicystic kidneys, mesoblastic nephroma, or any obstructive urinary process. With oligohydramnios, it's an amniotic fluid volume of less than 50 cc's and is indicated by the absence of pockets of fluid greater than 2 centimeters on ultrasound. And this is where it's most important for us to stratify these mothers who are at risk of their fetuses having any urinary obstruction. So the consequences of having oligohydramnios is the development of pulmonary hyperplasia. It is not the urinary obstruction that causes the fetus to demise, but it makes management of the child antenatally and postnatally very difficult as a result of the pulmonary hyperplasia. So they will typically present with the features that you see in the picture of Potter syndrome, and it's and the few features include flat nose, recessed chin, low set ears, bowed legs, a small chest, and a hyperplastic hands and limb deformities. So when it comes to the differential diagnosis of antenatal hydronephrosis, as you can see, there's a wide differential diagnosis. So it's from transient hydronephrosis, pelvic uteric junction obstruction, vesicoureteric reflux, megaureters, multidysplastic kidneys, a duplex kidney, posterior urethral valves, and other causes. So I just want to stress here that the role of transient hydronephrosis, what is that? So most children with an antenatal history of renal pelvis and calyce dilatations ultimately will resolve in their antenatal period. The etiology for transient hydronephrosis is a result of any narrowing at the UPJ junction or any natural kinks that will eventually fold as the fetus will develop. And this is then called transient hydronephrosis. You can see a majority of these children who've been diagnosed with antenatal hydronephrosis will eventually resolve, almost 41 to 88%. Most children with a pelvic dilatation of less than 6 millimeters were diagnosed during the second trimester, or less than 8 millimeters during the third trimester have transient hydronephrosis. So then this comes to the management and the way we should go forward with antenatal hydronephrosis. So what is the definition and what is the grading of antenatal hydronephrosis and how does it differ? So the severity of hydronephrosis is based on the anterior posterior diameter or the APD diameter on renal pelvis. Antenatal hydronephrosis is present with a fetal APD of more than and equal to 4 millimeters in the second trimester and more than equal to 7 millimeters in the third trimester. This is when further grading is then done with mild, moderate, and severe hydronephrosis. So the risk of postnatal pathology is increased with the degree of antenatal pelvic dilatation. Almost 80% of fetuses will show complete resolution of hydronephrosis or improvement in the second trimester. Any fetus with worsening hydronephrosis in the third trimester will show higher rates of postnatal pathology and likely to require surgical intervention. In severe hydronephrosis, the risk is about 88% to develop postnatal pathology. Hence, the grading system plays an important role in predicting which group of patients will require close monitoring up into the postnatal period. The other features on ultrasound that are important, together with the AP diameter, will also be used to predict postnatal outcome. These include poor cortomedullary differentiation, increased echogenicity, the presence of renal cysts, have been associated with the loss of function of the renal parenchyma. The presence of a perinephric uroma can be seen in association with severe urinary obstruction. So while monitoring antenatal hydronephrosis, one needs to understand if the hydronephrosis is bilateral or unilateral. And if detected, it is recommended that an ultrasound be done at 16 to 20 weeks of gestational age. This is in the second trimester to look for possible causes of any lower urinary tract abnormalities, renal dysplasia, and other extrarenal abnormalities. Features suggestive of lower tract obstruction include the following: bilateral hydronephrosis, oligohydramniosis, In this group, patients may require any form of karyotyping or chromosome studies for further testing, or a thick-walled or dilated bladder. Other poor prognostic features that must be looked into together as well. These include a perinephric uroma, progressive calyceal dilatation or ureter dilatation, features of suggestive renal dysplasia, and dilatation of the posterior urethra. So just about a few notes about what are the fetal interventions one can use in these group of patients and who must be, and which are the groups that we can recommend fetal interventions. So these interventions are recommended to oligohydramnios or features suggestive of early lower urinary tract anomalies. These groups are offered vesical amniocentesis, which measures the fetal urine and reflects the kidney function. When a fetus is present with these good prognostic factors that looks at the urine, sodium, the calcium, the osmolality, as well as the beta-2 macroglobulin and protein, these groups of patients can be offered fetal interventions. The two interventions available are vesicoamniotic shunting and the ablation of the valves. The ideal period to offer prenatal intervention for suspected bladder outlet obstruction appears to be in the mid-second trimester. This will allow for the return of amniotic fluid to promote fetal lung development. In terms of renal salvage to date, there is no randomized trial that exists to suggest that such interventions promote long-term renal salvage or reduce mortality in less severe hydronephrosis. So as Bernard explained about the Pluto trial, this is currently underway to classify the utility of fetal bladder diversion or vesicoamniotic shunting for fetal survival, fetal lung development, and renal salvage. Then finally, in the postnatal period, what is required? So the timing of the first ultrasound of the baby's birth is as follows. So any ultrasound that's done very early in the postnatal life, at least less than 3 days, is often underestimated due to low urine output and dehydration of the neonate. It is not a correct estimation of the APD diameter, so a delay of about 5 days must be followed. Postnatally, if the ultrasound is normal, the likelihood of developing pathology later on is about only 10%. And with a negative predictive value to develop a UTI is about 98%. Those with persistent hydronephrosis are likely to develop pathology up to 54%. So when it comes to grading postnatal hydronephrosis, the severity is classified into 4 different groups as per the Society for Fetal Urology by using the AP diameter of the renal pelvis as well as other factors. So neonatal hydronephrosis is defined of an SUF grade 1 or equal to more than 7 millimeters. The grading is as follows. So with grade 1, the urine barely splits the sinus. With grade 2, there's a full pelvis with major calyces that are dilated. And then grade 3 is uniform dilatation of the minor calyces, and at this stage the parenchyma is still spared. And then at grade 4, there's compromise of the parenchyma. So a meta-analysis suggests that anyone between the grades of grade 1 and 2, where the AP diameter is less than 12 millimeters, is 5 more times associated to stabilize, versus those who have grade 3 and 4 with an AP diameter of more than 12 millimeters to have higher odds of requiring surgery for intervention. So then when it comes to the follow-up ultrasound, if the ultrasound is normal, that's done in the first week, we would repeat the ultrasound in the 4th to 6th week. If it's normal, we discharge this group of patients, and we only repeat these ultrasounds if they are symptomatic. With mild hydronephrosis or grade 1 and 2, unilateral or bilateral, we repeat an ultrasound 3 to 6 monthly, and we follow up these children to at least for the first 2 years and perform ultrasounds every once a year. And towards the age of 5 or 6 years, we hope that their hydronephrosis should have resolved by then. But the group that's most important is the moderate to severe hydronephrosis. They require repeat ultrasound within the 4th to 6th week, and they need to be monitored very closely. So this comes to what are the different modalities that should be offered for the group that requires intense monitoring. So what is a micturating cystogram? What do we use it for? When do we perform it? And what are the indications? So it's a dynamic test used to demonstrate lower urinary tract issues and helps to detect the existence of reflux, bladder pathology, any congenital or acquired anomalies of the bladder outflow tract. The indications include unilateral or bilateral hydronephrosis with an SFU grade of 3 or 4 or an AP diameter of more than 10 millimeters with uteric dilatation, infants with mild grades of hydronephrosis who show progressive worsening hydronephrosis or progressive thinning of parenchyma, and infants with antenatally detected hydronephrosis who develop urinary tract infections. So we perform this to look for pathologies such as posterior urethral valve to quickly diagnose and prevent further upper tract damage by intervening quickly. Also, the association of VUR in patients with antenatal hydronephrosis is about 8 to 38% of the population. So therefore, we need to stratify which group of patients will benefit with antibiotics. So then the next study is a diuretic urinogram, or we use a MAC3 scan. This is a nuclear medicine scan where we use a radioisotope or a radionuclide material to investigate the function of the kidney using a gamma camera. And then we administrate diuretics to initiate the excretion of the kidney. And on the three panels or the three graphs that will demonstrate the perfusion of the kidney, the drainage, and then we look at these different curves to identify any point of obstruction in the kidney. So the indications for a renogram, which include infants with moderate to severe unilateral or bilateral hydronephrosis with absent reflux, infants with hydronephrosis and dilated ureters and absence of vesicular-uteric reflux, and patients with reflux with worsening hydronephrosis. The timing is usually done between 6 to 8 weeks. If it's earlier and there's presence of severe or worsening hydronephrosis, you would recommend an earlier need for a renogram. And then you would also perform the renogram a few times to actually suggest and demonstrate worsening pelvic-calyceal dilatation or PUJ obstruction. And then the last scan I want to let you know about is the DMSA scan. In our facility, we don't have access to this, but this is available in Red Cross, where it looks for renal parenchymal disease or scarring. It will usually show as cold spots during the infection or renal damage. And it's also a scan that can be used in an initial stage of acute pyelonephritis or when an infant presents with a UTI. Then what is the role of antibiotic prophylaxis in these group of patients, especially in the first year of life? So unfortunately, the evidence is still lacking. It supports the use of prophylaxis in moderate to severe hydronephrosis. And the benefit is that those that have established an APD diameter of more than 10 millimeters or severe hydronephrosis who have an increased risk of developing a UTI versus in mild cases. But there's a lot of controversies, and we'll just quickly go over what the controversies are. So in 2009, the American Urological Association looked at this, and they recommended the use of continuous antibiotic prophylaxis in this population for the first year of life. But more evidence suggests that actually the use of prophylaxis may in fact develop bacterial resistance. The Canadians said that they don't believe in continuous antibiotic prophylaxis, and they didn't give it a good recommendation, and it's still very under controversy. And then lastly, the latest study looked at that it had benefit, especially in the groups with high-grade nephrosis, and had a significant decrease in UTI rates versus those that received continuous antibiotic prophylaxis versus that did not receive it. So just to summarize, what should we be considering and what should we be doing? So these are the recommendations given by the Indian urologist. And in my unit, we give prophylaxis for all our children because the follow-up is very poor. So the recommendation so far is infants with postnatally confirmed moderate to severe hydronephrosis. That's an SFU of grade 3 to 4 or any AP diameter of more than 10 millimeters. You would give them prophylaxis while they're awaiting evaluation. Infants with postnatally confirmed hydronephrosis with uteric dilatation, that is the group you would be giving prophylaxis. And then it comes to the controversy with the use in VUR, because I've already mentioned that these group of patients have a higher risk of VUR in the first year of life. So the REVERE trial, or the randomized intervention for children with reflux, found that the use of prophylaxis was associated with decreased risk of reoccurrence of UTIs, but long-term, it did not actually improve your renal scoring. So just to sort of conclude about the use of prophylaxis before we go to the next one, it depends on what is the presentation of the patient and what your unit decides on. In my unit, we give all our children prophylaxis. And then finally, when it comes to the need for surgery, so when do we operate? If there's any presence of lower urinary tract obstruction, if there's an obstructed hydronephrosis with decreasing renal function and or worsening hydronephrosis, if there's bilateral hydronephrosis or hydronephrosis in a solitary kidney showing worsening or dilatation and renal deterioration, or if the patient presents as being symptomatic meaning a UTI, renal pain, they're not growing, or they have blood pressure issues. So why we operate is to prevent loss of renal function, to reduce the degree of hydronephrosis and associated symptoms, and improve the renal pelvis evacuation. The types of surgery we offer is ablation of the valves, as well as a dismembered Anderson-Haynes pyeloplasty if there's a diagnosis of PUJ obstruction. I just want to mention that a large portion of children with PUJ obstruction, those that have unilateral PUJ obstruction, are usually monitored for over a period. At any point there's deterioration or obstruction demonstrated on a renogram, we then would consider surgery. However, most of them will resolve, and we actually monitor those groups. If a renogram shows that the differential function is more than 40% and there's no features of obstruction, we would manage these children conservatively, and we will watch them and follow them up with serial ultrasounds. So just to summarize, we're back to the algorithms. So antenatal hydronephrosis is classified into the two groups, unilateral and bilateral, and classified into mild, severe. So if it's severe hydronephrosis, you need to repeat your ultrasounds more regularly in the antenatal period, and therefore follow them up into the postnatal period. And lastly, in the postnatal period, we repeat an ultrasound in the first 3 to 5 days. We classify the hydronephrosis. In the two groups of no hydronephrosis and mild hydronephrosis, this is the group that needs only monitoring. But the problem comes with moderate to severe hydronephrosis, where they need other interventions, as we've mentioned in the talk, when to use these interventions and investigations, what is the role of prophylaxis in those groups, and when do those groups need surgery. So to conclude, my take-home message is that the algorithms are actually the basis of how to manage these children. Most transient hydronephrosis resolves in the postnatal period. Persistent hydronephrosis requires investigation. The early use of these investigations is required to understand if there's obstruction or reflux, and early detection of bladder outlet obstruction is priority, as these groups of patients would need surgery. Thank you, and these are my resources.
Thanks a lot, Dr. Gautam, for the excellent presentation on the approach to antenatal hydronephrosis. Are there any questions on the floor or from everyone on the platform? Yeah. Dr. Cleveland has got a question there.
Thank you very much. Excellent talk. Just a question on the antibiotic prophylaxis. Do you have a sort of whether or not there's a diagnosis or not transient, or if it's reflux, do you have a sort of duration or sort of how long you would continue them on antibiotic prophylaxis, or is it sort of a case-by-case sort of thing if the hydronephrosis resolves?
So in my unit, we have, so I'll talk about my unit, what we do. So in the first year of life, because neonates present, it's very difficult to sort of understand urosepsis in that group of patients. It's difficult to diagnose it. So in the first year, when we're investigating them, we give them prophylaxis. And then towards they become older children, to diagnose urosepsis in that group is easier. So of course, if their reflux is grade 4, grade 5, they're at very high risk of developing recurrent UTIs. we sort of have a discussion around the patient and then we consider prophylaxis. In the lower grades, grade 1 or 2, we haven't given prophylaxis in those older groups. But in the first year, I think that is the most benefit. You want to protect the upper tracts at most importantly in those groups.
Thanks for answering that, Dr. Gautam. So what sort of antibiotics do you use and the compliance? Because obviously patients are on and off, there's the risk of resistance and stuff is the question from us this start.
So in our unit, we have access to not as many different groups of prophylaxis. We use sort of Bactrim, we use Amoxil. Those are the sort of groups that we use, and we recycle them every time in our unit. When it comes to the question of antibiotic resistance, I think it's still very difficult to answer that question to you. I think I'm really not sure how to answer that, because I've just seen in our group of sort of children in the neonatal period, when we've used that sort of strategy, we have sort of prevented the UTIs towards the first year of life. We got them diagnosed, we helped them surgically, but it's usually the older kids when we've stopped the prophylaxis, the compliance to that is very poor. The patients poorly follow up and they present in urosepsis in the older age. So I can't really comment about resistance at this stage. We're not maybe dealing with use of quite third line, fourth line antibiotics yet in our unit. So it's difficult for me to comment about that one.
Yeah, thanks a lot for that. You also mentioned, you mentioned the importance of doing a renogram in patients because not all, PJs are obstructed.
Yes.
And you said there's no access to that in Islam. Do you guys send all your patients to Cape Town for a renogram? I think you clearly mentioned the importance of the role.
We have access to a MAC3 scan that is done in private, and it's quite easy to book those investigations. And actually, we do perform the Anderson-Haynes pyeloplasty if they are requiring surgical intervention.
Yeah, no, thanks a lot, Dr. Gautam. I just want to see if there's any other comments. Just a comment from Kudzai and Zimbabwe. I think you guys may have seen that. I think it is quite evident that you guys did a great job in reviewing these two important pediatric topics. And thank you so much for excellent talks. And then good luck in your career and as a PhD, right? And thank you so much. I don't know if there's any other comments from Jeff. Probably around there. But once again, thanks a lot to you guys.
Yeah, he's running away around the corner.
There's a question from Dr. Gordon there, but I think she did actually answer that. She did answer that in terms of the kind of figures they look at. I think she said 40% from that. Yeah, but thanks a lot for that question, Dr. Cody. I think in the interest of time, we'll close off the session. We'll see you guys in the next week. Thank you so much.